Hi everyone, and thank you very much for the invitation to present at this declared conference. You will have heard already from my colleague Anne Cumming about the delirium care standard. I'm just going to put a little bit of context around the care standard, I guess from a clinical and a practical point of view. Anne and I have worked together for quite some time. I was involved with the Australian Commission on Safety and Quality in Healthcare as the geriatric medicine advisor when we were looking at revising the first edition of the clinical of the care standards generally, and certainly cognitive impairment was a really important part of that, and obviously delirium is a very important part of that. So I just want to start by telling a story, a true story, about a patient pre our awareness of the issues around delirium. I want to talk a little bit about what we did in New South Wales and how it fitted so well with the development of the delirium care standard, and then tell another story, again a true story, of a patient after our delirium program had been implemented and after we'd really started using the care standard in our day-to-day hospital practice. So, Mrs. R, and this is a story from 2009. She was a 78-year-old lady who lived with her husband in their own home in northern Sydney. She had early Alzheimer's disease, but she was managing daily activities pretty well with some prompting from her husband. She was working in the garden one day and had a fall, resulting in a fractured pelvis. She came in through our emergency department and was admitted to hospital with quite significant pain and immobility. She was managed in the acute wards of the hospital with regular analgesia, including quite high-dose opiates, and bed rest. Over the following day, she became quite confused. She was calling out. She was refusing to eat or drink anything. The staff believed this was due to her dementia. She was treated with haloperidol and lorazepam as she started to become very aggressive to staff. And then, of course, she became very drowsy and difficult to rouse. Her UTI was not initially recognised. She subsequently developed pneumonia, aspiration pneumonia, because she was so drowsy, and she required intravenous antibiotics and fluid supplements. Over quite a few days, in fact it went into weeks, she gradually improved with treatment in the acute wards, but she had 3 weeks in the acute medical ward in bed before she was able to move to a rehabilitation ward because she was considered medically stable. She was quite unable to transfer or mobilise without assistance when she moved to our rehab ward. She required 4 weeks of rehab before she was mobile and independent enough to be discharged home, and even then we were worried about her going. After return home, her husband reported marked worsening of her memory and day-to-day function, and she required regular prompting and assistance with many daily activities. It was only a few months later that she required residential care. So that was Mrs. R 12 years ago. What went wrong with her? Well, for one, she was admitted to hospital, and we know hospitals are very dangerous and unfriendly places for older people, for all people probably. She was confined to bed. She was given high doses, possibly unnecessarily, of opiate analgesics. She developed an unrecognised delirium, and her symptoms were blamed on her known dementia. And her UTI was not identified because the delirium hadn't been recognised and it wasn't managed appropriately. She was treated with a considerable amount of psychotropic medication. She became very drowsy, probably due to a combination of her hypo-alert delirium and to the medication she was being given, she developed aspiration pneumonia. How did this ultimately affect Mrs. R? She was sick for quite a few weeks. She spent a long time in hospital. She became very deconditioned physically. She never regained her previous level of function and mobility. Her dementia symptoms were much worse following her discharge home. And as I said, she required ongoing assistance with self-care and ended up in residential care about 6 months after discharge. So I think we recognised back in 2009, 2010 that we did not do delirium well in our hospitals. We knew that cognitive impairment was poorly managed, whether it was delirium or dementia, and that was right across the state, from small country hospitals to our large tertiary referral hospitals. We did know that there were good programs out there that have shown, a real effectiveness in managing delirium, such as the Hospital Elder Life program in the US, DEMDEL in Switzerland, and the concept of Joe Flaherty's delirium room in St. Louis in the US. And I think we had an understanding that early identification of cognitive impairment, treatment of the underlying cause, and management of the symptoms could prevent adverse effects or certainly lessen the duration and the severity of the delirium. We got together as a group of clinicians in 2010 and developed what we called the Confused Hospitalised Older Persons Program, otherwise known as CHOPS. Terrible acronym, but that was it, and it stuck. And it was a group of clinicians, and we had several consumers involved, and they were just fantastic in terms of giving us really good input into what worked and what didn't, and what it actually felt like to have a delirium, and particularly to be the family member of someone with delirium. We used a lot of information and guidelines. RMAC had put out something a few years earlier, and it wasn't like there wasn't enough stuff out there. It's just it wasn't being put into practice. We knew what we should have been doing, but we weren't doing it. So this model of care aimed to prevent, recognise and manage delirium, and we implemented it as a pilot in 5 New South Wales hospitals, a metropolitan one, a regional one, actually 2 metropolitan, 2 regional and 1 rural hospital over a 12-month period in 2011 and 2012. After that pilot, we refined the model. And we got a few more people on board. We had a really good steering committee that included a number of consumers, again, who provided a lot of information, people from the then Alzheimer's Australia, and others, all contributing to how to make this a better model of care. We developed 7 key principles, and these are going to sound a bit familiar, but they covered screening, risk identification, assessment, management, communicating with the family, education of staff, really, really important, and improving the care environment. And the rollout occurred in 12 New South Wales hospitals, right across from metropolitan, regional, rural and remote. Broken Hill Hospital was involved, and we rolled that out from 2014 to 2018. There is a very good website. If you just go to CHOPS ACI, you will find a lot of this information, particularly about the key principles for care and a whole lot of background information. Anne's already talked about the delirium care standard, and I'll show how I'll bring that in a minute. I just want to talk particularly about one of the key principles that we're not going to talk about necessarily in the delirium care standard, and that's the importance of the environment. It's actually principle 7, but it's one you can do a lot about. Just out of interest, this was our poster. We put it up right around the hospital so that family members would see it, staff members would see it, talking about the real importance of identifying delirium and how you could manage it. And I think the big thing was early identification, and we called it confusion because people didn't understand delirium back in 2012, but the big message was early identification of confusion may prevent adverse events, and we know that's absolutely true. So how do you provide a supportive care environment? And we actually developed an environmental audit. In fact, there is a whole book on this, again, available on the ACI, the Agency for Clinical Innovation website. If you just Google it, you will get the information about environmental changes. But before we started the program in those 12 hospitals, we looked at the environment, and it varied hugely. We had old hospitals, for instance, my hospital, Hornsby Hospital. The building was built in 1975, and it was 4 bedrooms with 2 4-bedrooms sharing 1 toilet. So it was pretty primitive compared to our lovely new modern hospitals, and we have just recently moved into new wards, and it's very, very different. But we looked then at the layout of the ward, where was the furniture, where was the, all the equipment that was always left lying around. And let me tell you, computers on wheels, cows, are so dangerous. We had several fractures, I think 2 hip fractures and several other fractures in patients who tripped over or ran into the computers on wheels. But layout of the ward was really important. Access, how do you get in and out? Is there reasonable lighting? Is there reasonable signage? The signage was absolutely impossible. We had bathrooms and toilets with no signage on them. And when we said to staff, well, how do you know it's a toilet? They say, well, we know it's a toilet, and we're the ones that take the patient. But there was nothing on it for the patient or the family members to see that it actually was a toilet or a bathroom. So signage was incredibly important and very easy to fix. Availability of low beds, so falls were less of an issue. Certainly availability of single rooms. We got very used to having people in 4-bed wards, and it's very, very different when you've got a single room. Although the advantage of 4-bed wards is that there are other people around to let you know if something's going wrong with one of the patients. Certainly the presence of large face clocks and calendars on the walls. Again, really simple to do, but it made a really big difference. It helped people, orientate themselves regularly. Colour contrast in bathrooms and toilets. All the toilets were white, the seats were white, the tiles were white. It was just totally impossible. We know that people with dementia have colour blindness problems. They lack contrast sensitivity. They're all visual changes that happen as part of particularly Alzheimer's disease. And so having everything all white is just asking for falls in the toilet. So we actually went out and bought a whole lot of black toilet seats at Bunnings, and it was very interesting walking out of that with, I think between us we had 20 toilet seats sort of on each arm. But gee, it made a huge difference. Certainly availability of appropriate chairs with arms beside each bed, so they could sit out of bed, and preferably one for the carer as well, although when you've got a 4-bed ward there's not a lot of space, but we made as much space as we possibly could. And we actually used one of the 4-bed rooms to develop a dining area, which was also the lounge area, which also doubled as the gym area, and unfortunately also was used to store equipment quite often. And it was where we had our team meetings, but it was absolutely terrific. And the staff would bring patients down to the dining room to eat their meals, or certainly for lunch. That was revolutionary back in the 2012 2013, 2014. You kept people in bed in those days, but to bring them into the ward's dining room, to normalise it for them, was just terrific. And we had the rule, you had to have 3 tubes or less to go into the dining room, otherwise it got very difficult. We also were very keen on having access to outdoor areas. We didn't actually have that in our model at Hornsby Hospital, but a number of other hospitals did develop a model or sort of renovated to allow access to outdoor areas. It is just so important, and the ward environment plays a huge part in ongoing care of older people. And I just give you this as visual examples of some of what we did. Top left-hand corner, the Aged Health Network, the book I mentioned on the principles for improving environment, available for download. The calendars and the clocks that we used, decent sized name tags for the staff, signage on the doors so people could see what we were doing. There are our black toilet seats from Bunnings in place. Makes a huge difference. The bottom row of pictures is interesting. We painted the rooms in our delirium unit different colours, and we put sort of patterns on the doors so people could remember they were in the blue room or the yellow room, and that worked really well. This middle picture of trees, do you know that is the entrance to the ward or the exit to the ward, as you can see by the fire exit sign above it. Now, can you tell that there are doors there? There actually are. And on the right hand side is our wonderful bus stop. This worked so well. There's no one sitting at the bus stop at the moment. I had to move them because I didn't have permission to photograph them. But that bus stop worked wonders. And because we had at that stage a circular ward, people would walk round and round and they'd come back to the bus stop and sit down again. A wonderful way of making people feel that it was a little different and it wasn't too institutional. Okay, so that was just highlighting one particular area of our response to delirium. But it was really interesting because while we were developing the CHOPS program and rolling it out and doing the education and collecting the information that showed it was working and people were becoming very confident in understanding what delirium was, the delirium care standard development was also underway. It was launched at the delirium conference in Sydney by Gideon Kaplan in mid-2016, and Joan Jackman, who was the consumer who was very, very involved. She was actually an OT whose husband had younger onset dementia. She actually, I guess, did the proper launch along with Gideon. Having that care standard was really good motivation for hospital managers to look at implementing the CHOPS model of care. Please do not underestimate the value of this sort of carrot and stick approach. You know, you talk about the delirium care standard and how wonderful it is and it makes for so much better patient care. But then when you mention that you also have the issue of accreditation coming up, and this will help you tick all those boxes around cognitive impairment if you bring the CHOPS model of care in, once you've done that, you really, really get engagement. And it's interesting because you look at the principles or the quality statements in the first delirium care standard. You've just heard about the revised delirium care standard, but again, early screening, assessing for delirium, interventions to prevent delirium, treating underlying causes, preventing those dreadful hospital-acquired complications, minimising antipsychotic use, and then making sure it was a good transition out of hospital care. And just looking at that, preventing falls and pressure injuries, we spent probably 10 years raising awareness of delirium, getting medical staff to talk about it, think about it, write it in the notes, Now, unfortunately, it's a hospital-acquired complication, and we actually get penalised if we have hospital-acquired delirium. So it's kind of come full circle, and I think we really have to deal with this. We're really proud of the fact that people are recognising delirium and talking about it. We don't want to get punished for that as well. So we're working on that at the moment. And certainly the inclusion of cognitive impairment in the second edition of the quality standards, that's really encouraged hospital managers and directors of clinical governance to really get on board with a good model of care for people with cognitive impairment. Okay, so fast forward to 2020. How might Mrs. R from 2009, how might her story change because of what we've done in the intervening 11 years? And this is, again, another true story from last year, Mrs. D. She's an 81-year-old lady, again, mild dementia, lives with her husband in northern Sydney. She fractured her pelvis when she fell over one of the sort of traffic stoppers in the car park at the local shopping centre. It was a bit tough. She landed on fairly hard concrete. She came into the acute wards through our emergency department, where she had been screened for delirium using the 4AT, which I have just shown here to remind me that's what we used. She was given regular paracetamol and non-steroidals and a very small dose of codeine overnight because she was in considerable pain initially. As I said, she was screened for delirium on admission. She was noted to have short-term memory problems, but good attention. So yes, she had cognitive impairment, mild dementia, but she did not have delirium on admission. She was reassured that her pain and mobility would improve, that we would look after her as best we could, and her family, her husband and daughter, were given information about the likely progress of the pelvic fracture. They were shown the x-ray with the crack in it and explaining that you don't do operations, you just look after them supportively. And we explained the possibility of delirium, gave them a delirium brochure, and got them keen to be involved with their wife and mother's care. And we actually have carer chairs beside the bed. They're a revolting lime green colour, so no one will nick them, but they're really good, and people can actually sleep in them quite easily. Mrs. D was nursed sitting out of bed as much as we could get her out of bed during the day. She was encouraged to drink fluids regularly. She was stood up in a forearm support frame, within the limits of her pain, and her family visited regularly. They were there. There was someone there almost all the time, and for 3 nights, her daughter actually slept on the carer chair next to her. So they were there to orientate her and support her. The ward was, it had bright natural light, it had lovely big windows, there was a clock on the wall, and there was space around the bed for the family. So, looking at the quality statements you've just heard about, how did we meet Mrs. D's needs using the new delirium care standard? So early identification of risk. We knew she had dementia. We know that having dementia gives you up to a 5-fold increased risk for developing delirium. So we knew that. And she was noted on admission to have cognitive impairment on the 4AT, but no delirium. So it was identified she was at risk. The second quality statement, how to prevent delirium. What did we do with Mrs. D? The risk was identified, her pain was treated adequately but not over-treated, and we used 2 different forms of analgesics, the paracetamol and the non-steroidals, because her renal function was okay. We sat her out of bed because this prevents delirium. She was constantly orientated to where she was and what had happened. She was eating and drinking reasonably well. We did have to encourage that. The family were present to help with all this, and the environment was appropriate to maintain cognition, with good lighting during the day, and then at night it was quiet with just a night light. And I think it's really important to the importance of that appropriate environment. The other thing was she was not moved from one room to another. The only moves she made were from the emergency department to the acute wards, and then a little later from the acute wards over to our rehab ward. These patients that get moved around the hospital into different wards, it's no wonder they develop a delirium. I think I would if I woke up in a different place every morning. Quality statement 3, patient-centred information and support. Mrs. D was given simple information about pelvic fracture. We had to repeat it a few times, but she was reassured regularly by nursing staff and by the physio that she would improve. And every time she stood up in the forearm support frame, she was really encouraged. And her family were there to see how she progressed. Because they were given information about delirium and its prevention, they could help us with managing this lady. So, continuing with Mrs. D, she was screened daily. In fact, she was actually screened twice daily for delirium. On day 3, she did become quite agitated and aggressive, and her husband said, as with the morning round, when the doctors came round, he said to the intern, "She's really changed in the last 2 hours." And that intern perked up his ears, organised for immediately a urinalysis, and we sent off a culture and sensitivity. But the UTI was recognised and it was treated with antibiotics within hours. The family were present to provide support and just keep encouraging her because she was getting a bit grumpy. And it was interesting, her agitation resolved after 25 hours, and it was 25 hours because they commented from 10 o'clock on one day to 11 o'clock the next. It was very interesting. And no psychotropics were used. It was really good. We managed her with the analgesics and regular, I guess, reassurance and support from her family. She moved to the rehabilitation ward after 6 days, so on day 7. Once she could take a few steps without strong pain, and we still had her in the forearm support frame at that stage. When she got to the rehab ward, she was dressed in street clothes. She attended individual exercises, physio, and also group exercise. So we kind of normalised it. You can see a picture of the group in the ward doing some very simple exercises on the parallel bars to music. She was encouraged with her own self-care and grooming. She was discharged home 3 weeks later, so that's 4 weeks after her original admission to hospital. She had home-based physiotherapy to transition her from a walking frame to a cane, and then eventually to no aid at all when she became confident. And there was no obvious significant worsening of cognitive impairment or of function, according to her husband and her daughter. So, quality statement 4, assessing and diagnosing delirium. She was screened daily, twice daily actually, the 2 shifts, morning and afternoon. Her change in behaviour was noted fairly quickly, good on the JMO for picking that up, and her delirium was diagnosed. Quality statement 5, identifying and treating underlying causes. Her UTI was recognised and treated not just with antibiotics but with extra fluids, and making sure that she was passing plenty of urine. The fluid intake is so important, and her family were there to assist in day-to-day care, and she was taken to the toilet, although it was quite painful for her. She was wearing pull-up pads as well, although that concept of saying "wee in your pad", I really think that's very undignified and undignifying. 6th quality statement, preventing complications of care. And boy, is this important, because we know delirium leads to so many negative outcomes. She was kept out of bed as much as possible. This has been a real change, certainly with nursing. We now nurse out of bed as much as we can. She was mobilised in the forearm support frame within the limits of her pain, and we made sure she was given pain relief about 20 minutes, half an hour before the physio came to get her standing. And then when she was just sitting in the chair, her husband would do simple exercises with her, or our physio aide or the physio would come and do a little more with her. She was kept orientated to what was happening around her. Adequate fluid. I keep talking about fluid, but it is really important. This time we were aiming to prevent constipation. And she was encouraged, even in the acute wards, to do a little bit of her own personal care, her grooming, cleaning her teeth, doing her hair, those sorts of things. We need to prevent the learned helplessness and the functional decline that occurs when we hospitalise older people and don't let them do anything. 7, avoiding use of antipsychotics. Our poor old medical staff have been hammered left, right and centre about really the very modest efficacy of antipsychotics. They seem to be the go-to medication, but they often don't work. And I think it's really important that message is getting through. So we didn't use actually any psychotropic medication. Other management strategies we used to manage her agitation, including her family being there. That made a huge difference, particularly, having her daughter there. And finally, transition from hospital care to home. She was ready for discharge home by attending to her own personal care and dressing while she was still in hospital. So we were it was like a halfway house. There was a home visit with your occupational therapist, just a brief one, not with Mrs. D, just by the OT went by herself, just to check that the home environment was safe. There was ongoing physiotherapy in Mrs. D's own home environment, so it was familiar and it enabled independence. And her confidence improved fairly dramatically, and she moved from the frame to the walking stick to independent walking. So how did this affect Mrs. D when you compare her to Mrs. R? So really 11 years later. Her delirium was recognised because staff were alert to its development. She was only unwell for a short period of time because we got in with the treatment fast. She was mobilised within the limits of her pain. Keeping her out of bed is so important. Family members, I've said this again and again, very important to spend time with her and making sure her fluid intake was good. She moved to the rehab ward quite quickly, so she didn't spend too much time not doing very much. She only spent 3 weeks there. She was transitioned home with our home-based rehab, and she pretty well regained her previous level of function and mobility. And I hope that reflects what we are all doing now and what that delirium care standard has really helped us to do. So thank you very much, and I think we're going to move on to the panel now.